Hello, I am Larry Tannenbaum. I'm pleased to have the opportunity to present this material on artificial intelligence and neuroimaging. We'll spend some time talking about, what AI is, a little bit on the hype and reality, a tiny bit on the terminology and background, strengths and limitations. We are limited in terms of time here, so you won't get much of that. And most of what we're going to talk about is going to be on the impact of AI and neuroimaging, and we're going to focus on quantitative neuroimaging, the triage applications very briefly, a little bit more on image reconstruction, which is what my area of passion is right now, and then we'll sum everything up and discuss what we've learned. What is AI? AI is a branch of computer science that allows machines to do things that are normally associated with human intelligence, reasoning, learning, and self-improvement. It's essentially a technology that enables machines to do the things that we do: sense, comprehend, act, and learn. You can see that a fair amount of money is being spent on AI in the healthcare space, ever increasing, as you can see. And some of the big OEMs, the ones that are associated with the hardware that we buy, that we use for imaging, are making the biggest investments and filing the greatest number of patents. You can see when it comes to analysis that AI and big data, essentially the same space, are the key technologies to impact healthcare by a wide margin. And even back in 2018, about half of the healthcare organizations were either actively involved with some form of artificial intelligence, machine learning, or actively planning to get involved. And we're now, late in 2020. AI is essentially all around us. I can't tell you how disconcerting it is to find the ads for things that I've looked for following me to every web page on the web, and whether it's crowdsourced traffic information or knowing where I'm going before I enter it on my Uber app, it is everywhere all around us. Because we're short of time, I'm going to jump right into the active part of the presentation, and that's where I show you this particular slide of all of these individual entities that are actively involved in artificial intelligence, machine and deep learning in the healthcare sphere. This is a wonderful slide that I stole from Hugh Harvey, which talks about all the different applications where AI can impact on the imaging enterprise. And we'll touch on a few of these, right? We'll touch on automated acquisitions. We'll touch on dose reduction and scan time reduction. We'll even talk about diagnostic inference and decision making, and we'll spend a fair amount of time on segmentation as well, but focusing on the impact in neuroimaging. So starting with the actual acquisition on the device, every vendor now has a version of automatic scanning, and GE will be the latest entry to the field, but their application is truly a deep learning based application. We participated at RadNet in creating this particular tool, but all of the vendors have tools for automatic scanning that use some form of machine learning, and many of them have a full head to toe suite as far as this, in terms of how these things will work. And you say, what difference does it make who runs the scan? Well, there's a lot of things that can be more consistent and more reproducible when you have the scan set up automatically than when you leave it to the vagaries of the individual technologist. In fact, we've actually looked at our institution on productivity benefits, and here you can see a slide comparing two different scanners in the New York City area. Both of them, the same scanner model. One had automatic scanning engines, in this case Siemens dot engines, and one didn't, but same radiologist, same protocols, same scanner model, one having dot engines and one not. And you can see the average scan time with the dot engine is lower, and by a significant amount, several minutes, less time spent doing these exams because the machine is doing the setup. The next area I'd like to talk about is in segmentation. As you probably know, segmentation is one of the lowest hanging fruits for artificial intelligence, and this is being now used clinically in a number of different circumstances to do things like look at MS lesions, look at gray and white matter volumes, even looking at ventricular volume. We know the situation in multiple sclerosis. It's a very challenging task to be able to pick up the new lesion when somebody's got 20 and 30 lesions. It's kind of like trying to count the spots on a Dalmatian. You never really get the same positioning. It becomes a very difficult task. And this is another area where automatic and 3D scanning can make a difference. The folks over at Icometrics actually took a set of data in a patient with MS and showed it to 84 participants, and you can see a highly impressive, or you could say depressing, variability in the number of individual lesions identified by the individual readers. So there certainly is a task that needs to be done. The challenge is very, very real. Now, that just comes to counting lesions. What about volume changes? Some of them are bigger, some of them are smaller. This sort of falls into things that go beyond what I can actually perceive. And that is another theme of artificial intelligence, is taking us beyond the level that humans can usually do in a routine setting. Now, typically, we rely on contrast enhancement to at least give us a sense of the active lesions. And here you can see a mag transfer scan and a T1 scan post-contrast, which tells us that this little tiny lesion here, this is 3D FLAIR, 3D double IR, and routine T2. This little almost imperceptible lesion here turns out to be the active lesion. And as you may know, the Centers for MS Consortium actually has now taken contrast out of the routine use and only made it optional in some selected scenarios. So we're going to see less and less of this contrast. And this is largely because of some concern, despite the evidence of harm in any way, a slight concern over the use of gadolinium repeatedly in this patient population. So where does machine learning come into play? Well, traditionally it's done in the segmentation process, but increasingly we're starting to see improvements in the segmentation of these lesions and of the normal structures, augmented by true deep learning. They're not really on the market as yet, but they will be eventually. But even with machine learning, you can see the impact in these particular cases. On the left-hand side, you see a 3D FLAIR from 2018. On the right-hand side, you see it from 2019. And in the middle, you have the 2019 exam annotated for new lesions in red, lesions that are enlarging in yellow, and pre-existing lesions in green. And you can just get a sense how challenging this is, just having it roll by your screen. But it's so nice to be able to have these things highlighted. You can see in red here, when you compare it to the 2018 exam, you don't see a lesion there. So that's clearly a new lesion. This area right here in yellow is enlarging. It basically took this lesion out to a larger area. And you can see the little pre-existing lesion right there in the middle. Makes it a lot easier to read. And frankly, I would argue it certainly would improve the quality of my work. You can see, you get these reports from these segmentation exams, which are inherently quantitative. You get the volume of lesions. In this case, we've lost overall lesion volume by about 9 mLs, but there were new lesions, some of which were enlarging, some of which were shrinking. And this can be done for both the FLAIR and the T1 hypointensities in these cases. You can see the kind of reports you get. If we zoom in just a bit, you can actually see what's happened over time. This particular patient has actually lost some brain volume over time, not so bad in the gray matter. And you can see just below the 50th percentile in whole brain volume and just above the 50th percentile in gray matter volume. More importantly, when you have these automated quantitative tools that are based on deep learning, you can improve the quality and value of our report by reducing things like inter-rater and intra-rater variability, which was shown in Seema's paper in 2018. I think it's clear that we are going to be more accurate. Without the quantitative tool, things were felt to be stable in 3/4, progressing in 24, whereas with the greater sensitivity and accuracy of the tool, you saw a number of additional cases where progression was identified, which I think is very, very important in terms of guiding treatment. And here you can see that treatment changes would have been made, as well as making the study more valuable, and perhaps even most importantly, in busy centers, is just more efficient. The readers are much more efficient, and because it really had that virtual resident sitting over your shoulder, counting those lesions and pointing out the ones that may be larger or smaller. I think it's very powerful stuff. Similar tools can be used in traumatic brain injury. Again, the deep learning piece, the machine learning piece is done in the segmentation. And I would anticipate that true deep learning may further refine this, but they can do things like measuring the volume of hemorrhages, epidural, subdural, parenchymal, looking at cisternal volumes for compression, quantifying midline shift and ventricular dilatation, and again, putting this against a normative population, and again, doing the segmentation. Here you can see different segmentations, both for the hemorrhage as well as the ventricles and cisterns sliding by on the screen. Again, a machine learning application And if you take a look at the actual image here, this is a nomogram, which actually gives you just sort of an overall quick gestalt as to where we are. And you can see the ventricles in this case are both compressed, worse on the left than on the right. In the middle, you're down to below the 1 percentile, and you can see virtually maybe a little compression of the suprasellar cistern as well, but no other compression you can see in this particular case. With these quantitative measures, however, we then add value for our referring clinicians by being able to give them the data points they need to fit into their clinical scoring scales, which would then actually drive their outcomes and patient management, which I think is really important and does take us one step further to being a more valuable member of the multidisciplinary team. These tools probably started out in the evaluation of dementias, and here you see two different commercial products here on the screen, and the way they actually look at the individual areas of brain involvement. As you can see, segmentation again, really nicely done of all of the superficial and deep brain structures is really, again, a low-hanging fruit for machine learning tools. As neuroradiologists, we know that there are certain volume loss phenotypes, certain patterns in dementias that if we can be more sensitive and have the ability to compare to a normative population, we can identify these findings with greater facility than the human eye, which tends to sometimes reject subtle asymmetries. And I think we all know that in Alzheimer's disease, the atrophy is going to be hippocampal, temporal, and parietal, whereas frontotemporal dementia will be more hippocampal, temporal, and frontal predominating. A vascular dementia really with no specific finding, and a Lewy body dementia really no specific atrophy. Note that in the vascular dementia, the white matter lesions are more common. If you look at these nomograms, and here again, you see the atrophy can be seen as pointing to the outside of the curve. In the normal case, the diamond is in the middle, but in a frontotemporal dementia, we've lost volume in the frontal lobe and temporal lobe. And in an Alzheimer's case, we've lost volume in the hippocampal, parietal, and temporal regions, sparing the frontal region. And with these nomogram eyeball cases, I think you can get a much more quickly acquire a gestalt as what's going on the case, and perhaps even more importantly, it would be very difficult from a visual standpoint in some cases to be able to evaluate change between exams, where here you can see the red arrow pointing to the previous time point, and now you can see it has extended to involve more of the frontal region on the follow-up exam. Note that there hasn't been much change in the hippocampal and temporal cortex. Perhaps those were burnt out already, whereas now it was extending to the frontal cortex, which can be important for treatment. This is a case that Dr. Bash loaned me, really nice, two different incidences on this particular patient, seen in 2009. You can clearly identify on this axial slice through the temporal lobes that there is volume loss. You can see on this PET examination that there is clearly diminished tracer in the anterior medial temporal lobes. When we fuse that to the MR, you get a really nice correlation that the atrophic areas of brain are really hypometabolic. Patient came back in 2016. At this point, had quantitative neuroimaging assisted by machine learning, but also had an amyloid PET scan, which clearly demonstrate the diffuse staining loss of gray-white matter differentiation indicative of Alzheimer's disease. And you can see this particular case, the nomogram points to the hippocampus, frontal, and temporal cortex as being strikingly atrophic in this particular example. Okay, what else can you do with machine learning and deep learning in radiology? We're already seeing significant penetration of triage apps into the routine day-to-day setting, and thanks to the AI doc folks for giving me a few of these cases. They've got an FDA-approved application which will detect subtle cervical fractures, perhaps most important on whole body studies when we're not tuned in to these types of fractures. Here's a patient that was seen for a whole body study, sent over without a collar. It was limited concern about cervical injury. There was focus on the abdomen, but you can see in this case, the tool essentially elevated it to the top of our list saying, hey, read this case first. There's an urgent finding here. And the neuro team was able to notify the treating team that collar precautions were necessary because of this fracture. Similarly, the tool has the ability to move or triage cases to the top of the list. This patient had head trauma. The initial interpretation by the radiologist called it normal, but the tool had identified these small hemorrhages and moved it to the top of the list. This case, again, was pushed to the top of the list, even though the original radiology read did not see any acute bleed. I'll show you the arrow that AI Tech gave me, and I can see that. I don't know that I would have called that. With this arrow here, then I might have noticed that there's a crescent of hyperdensity here, but I don't know that I would have seen it otherwise. This patient went home. It wasn't seen. You can see that it developed several days later into this large, clinically, surgically significant extraaxial hemorrhage, which then needed to be decompressed. Perhaps if the patient was seen in the hospital, if this was seen initially, closer surveillance and a less dramatic presentation would have been ensured. We don't have time to talk about this today, but there are a number of tools that are available for AI and stroke that are revolutionizing the workup and treatment of patients who present with large vessel occlusions. There are machine and AI-driven perfusion apps. There are automatic aspect apps. There are tools that recognize LVOs and even notify the treating team and pick out selected images. I think this has really made a big difference in this particular setting. There are even tools that are being used for spine imaging, and I'm going to show you one that is actually useful for assisted interpretation, reporting, and workflow. This is some work that was loaned to me, currently a work in progress from a Bulgarian company called Colombo or SmartSoft, and their particular tool actually can do a number of parameters around the spine, including vertebral height and subluxations, as well as identifying things like herniations and identifying the position of the nerve roots, and essentially taking all of this information in a fairly robust and impressive fashion and actually translating all of that into a pre-populated report. Now, you take an exam like lumbar spine, which in our organization is the #1 exam we do. When you realize the detail that is required to get all of this information in print, as well as the striking and distressing variability between radiologists, perhaps even within a radiologist over a course of a patient's lifetime, these tools can add a significant amount of consistency and standardization, as well as the ability to data mine, if that was your ilk, by using these tools. Again, these tools are really great at segmentation. There are a number of folks working at lumbar spine segmentation as well. Here you can see a little bit of a spondylolisthesis, which is being categorized at L4-5. All right, what about image reconstruction? Well, even things like compressed sensing are essentially an application of machine learning, but we'll talk about compressed sensing, iterative reconstruction, and true deep learning-based reconstructions before we're done. As you know, with compressed sensing, it is a very extreme form of parallel imaging. When we do half neck scanning, we count every other line. We go into parallel imaging. We do it in a much more flexible fashion, which actually even allows us to get inside the field of view without getting aliasing. With compressed sensing, we're doing a very creative, really drastic undersampling and using tools like machine learning to reconstruct an image from very, very little data. The practical applications of compressed sensing are several. One, it can actually accelerate your routine imaging by 50% or more, which has an impact obviously on throughput, on the patient experience, and the value you can add into an examination if there's something else you wish you could have done. It also allows you to do academic style volumetric imaging with sub-millimeter voxels in a practical scan time, which is what this slide demonstrates. Here you can see a routine 3D flare. We do 3D flare in a lot of our institutions, and there's always a complaint about softness of the reformatted images. When you get isotropic, it's very difficult to tell which one was the acquisition slice, and that really is our goal. In this case, it's a sagittal acquisition, and the axial images look very much like a direct acquisition. When you do things like MR angiography, unfortunately, this is not moving. Oh, there it just decided to move. Where the data is very black and white, the data is very sparse, you can get a full 50% reduction. Something that would ordinarily take 4 minutes is down to 2 minutes, and we probably have 50 scanners in our network that are running MRAs of the brain, maybe 75 actually now, in 2 minutes as opposed to the 4 to 6 minutes we did in the past. Again, impacting on workflow, impacting on the resolution that you can actually run, and certainly impacting on the patient experience. Now let's talk about iterative reconstruction. Again, a undersampling method, whether it's undersampling for dose, undersampling for signal, that is enabled by machine learning. And this is one particular commercially available tool from a company called MedicVision that actually uses a machine learning assisted iterative reconstruction method to accelerate spine imaging. We've actually done some research work with this particular application. I'll show you some of our results. Essentially, we took a 33% time reduction off the routine protocol. That's what you see here on the right. And use this iterative reconstruction tool to restore image quality. So this is 33% faster than that. Everything else is exactly the same, yet the image quality looks about the same. As a matter of fact, in this particular trial, we showed non-inferiority for all measures in the brain. When this thing is 3, when you see a score of 3, you know you're dealing with a non-inferior circumstance. So in the brain, the accelerated process scans were essentially identical to the original scans. Here you see some spine work. The original protocol is 249. The accelerated protocol processed with iterative reconstruction, just like we do on CT, 50% faster. In this particular case, you can see reasonable image quality, and blinded reviews by the readers showed the same non-inferior status of the imaging. A couple of cervical spine examples, same thing I've showed you as before. And again, in this particular case, again, non-inferiority for all measures. So it shows that iterative reconstruction, much as you do with CT, can give you image quality that matches routine image quality in less time. Now, we are familiar with iterative reconstruction with CT, right? It allows us to use doses that are so low that with traditional filtered back projection techniques, the images are almost non-diagnostic. But using an iterative reconstruction technique, this is a model-based iterative reconstruction, you can see the image quality becomes outstanding, certainly with lower noise levels than you would have without it. Going beyond iterative reconstruction to deep learning allows us to not only get the noise reduction, but to restore the look to the images that we've always loved. Here you can see a standard filtered back projection at today's low doses, very noisy, a lot of salt and pepper in the brain and in the ventricle. Here you see typical iterative reconstruction with an image quality that maybe is not what you like to see. And here you can actually see what the true deep learning based iterative reconstruction can do. So it creates an image closer to what we had in the old days when dose was not foremost in our minds. There are some significant benefits to deep learning based reconstruction over traditional iterative reconstruction. You can see it here from these slides. So notice how, whether it's bone acrylic or I think that's polyacrylate, whatever that PE stands for, when we image with filtered back projection, the curves all overlap. Okay, that's the behavior in tissues we expect. When we go to both iterative reconstruction and model-based iterative reconstruction, you see the curves diverge, which means these tissues behave differently on those with those reconstructions than we would have traditionally expected with traditional reconstruction, and this causes concern to some. It really is very reassuring that when we use deep learning-based iterative reconstruction, deep learning-based image reconstruction, we get the same look. Here you see filtered back and deep learning. You see all of these dosed phantoms at 120 kV, 170 kV, all the phantoms look the same, which again is just a visual illustration of the fact that these tissues behave the same way as on FBP that they do with deep learning reconstructions. But you say, well, what I'm really complaining about on iterative reconstruction is the funny feel to the image. And that is a reflection of a shift in spatial frequency, in noise power spectrum, was what I should have said. And you'll notice here, this is iterative reconstruction in yellow. You have the routine image in blue and the deep learning image reconstruction in brown. You can't see the blue and brown because they overlap, because they have the same noise power spectrum. So iterative reconstruction shifts the noise power spectrum, which is why the images look funny, where deep learning iterative reconstruction doesn't, which means you're getting the traditional look to your images, albeit at lower noise levels than you've always had and loved. And here you can see a typical example, iterative reconstruction on the left, deep learning reconstruction on the right, GE's True Fidelity. Canon also has a version of this, and I believe there's a Korean company called Clara Pi, which has a version of this, but you can see you get an image that looks very much what you'd expect. You can see, again, this is a typical deep learning reconstruction. Notice none of the altered texture, little high noise levels on this particular image, none of the altered texture that we complain about. Now, That would be exciting in itself, but when you start applying these tools to MR imaging, it's even more exciting. And here there are several players. Again, you've got GE's new Air Recon DL, you've got Canon's new ACE. Both of these are FDA approved and being sold. And you also have subtle MR's deep learning reconstruction. So all three of these are available, and I'll show you examples of each. Here you can see something from the Canon scanner, and it shows you what you can do with some of these tools. You can actually dial up a spatial resolution that is so high that there's really no way to get to a quality image with that field strength. We all know there's a limit to what we can do at 1.5, there's a limit to what we can do at 3T, and there are dreams of what we could do at 7T if we could have these in the clinical setting. Imagine you could dial up a 7T-like acquisition, do a reasonable job at building signal, but then using a deep learning algorithm to restore the signal to noise and maintain the contrast resolution. And yet that is one of the things that people are doing with these deep learning algorithms. Here you can actually see a 2D sub-millimeter acquisition, okay? And that's what you see here on the left. You'll notice this is a noisy image, okay? We can apply conventional noise reduction, which every scanner has, and we can reduce the noise, but it really creates a somewhat altered texture, and it really doesn't get to where we need it to be. Whereas when we use deep learning here on the right, this becomes almost a spectacular image with incredible detail, incredible sharpness. And one of the hallmarks of these deep learning reconstruction techniques is you don't lose sharpness. Here you can see 0.9 millimeters went from here to there. And again, look at all the little detailed pieces of information that are preserved, but the noise is removed. Look at the prevertebral soft tissues. Look at this annular fissure. I mean, I think that's really remarkable. So we actually did an abstract for several of the recent meetings looking at the impact of these tools in brain and spine. We looked at 93 image sets. For this particular algorithm, the K-space data goes from the scanner and gets two different reconstructions, conventional and the deep learning reconstruction. You can see how it took this scan and turned it into this scan. These are not two different scans now. Same K-space data made this one with the conventional recon and this one with the deep learning recon. Again, same data. Notice the sharpness is actually preserved, actually sometimes even enhanced. The signal to noise is certainly improved, and the image quality is really very pleasing in these cases. Again, conventional reconstruction, same K-space data, deep learning reconstruction. You can look at the detail around the corticoquine nerve roots. Again, same data, routine imaging, higher resolution, higher contrast resolution, lower and much lower noise. Look at how all these structures are preserved, much lower noise with the deep learning reconstruction. This is a nice scan, particularly if you ignore the prevertebral soft tissues. But notice how much cleaner it is with the deep learning reconstruction. Again, a nice scan if you ignore the prevertebral soft tissues. Same scan with deep learning reconstruction. Let's take a zoom in. Notice how we can actually appreciate more of this high intensity zone here. This perhaps, peripheral radial tear here might also be better seen. Look at the basovertebral venous plexus. We're not losing any data, yet we're getting a much lower noise, and you can actually appreciate a higher spatial resolution. The end plates are sharper. They're less jagged due to reconstruction failures. And if you look carefully, you'll notice the cord actually looks a little bigger. When resolution goes up, structures, you look to the human eye as if they're bigger. Again, conventional, a little noisy, deep learning reconstruction. Conventional, on an older scanner, deep learning reconstruction. Conventional, deep learning reconstruction. I think you're getting the theme here. And when read blind, well, it's kind of hard to read them blind because it's easy to recognize the deep learning recon. But in all of these cases, the readers rated the deep learning reconstruction statistically better with significance 0.05 for all of the measures we looked at, including overall quality, lesion conspicuity, contrast resolution, perceived spatial resolution, perceived SNR, and perhaps most importantly, image texture. It is important to know that we don't lose the quantitative values. Here you can see some DTI fractional anisotropy data from a Canon scanner showing that their deep learning reconstruction doesn't sacrifice quantitative measures. I think I already showed you this one. That didn't mean to be there. There was one more player in this field, and that's Subtle Medical. This is an image space-based application where you do the scan, it goes to their servers and comes back, in a moment or two, processed by deep learning. And we actually gave them the challenge of reducing our scan times by about 2/3, really leaving only 1/3 of the scan time. And we just submitted this manuscript to the AJNR in July of 2020. And here you can see the particular example. This is the standard of care exam here, T2, T1, STIR, PD, axial T2 and T1. And here you can see the accelerated exam, 41 seconds, 87 seconds, 73 seconds, 47 seconds, basically a third of the scan time we had before. We looked at 61 patients, multiple different spine exams. Here's just another example, the standard of care here, the fast processed images with subtle MR software. And you can see, at least superficially, the study looks good. As a matter of fact, you can see some of these artifacts have been recognized and eliminated by the reconstruction. So again, process with a deep learning algorithm. Here you can see standard of care, the deep learning exam, the fast accelerated exam here, and then we gave this exam to the algorithm and it came back with this result. So this exam became this exam, which compares favorably against the standard of care exam. We looked at all the usual measurements. We don't have time to talk about them here. Again, same thing. This exam became this exam, which compares favorably with this exam in only 1/3 the time. Okay, we did all the usual comparisons. I'll skip this one in the interest of speed. But what we saw was the standard of care compared very favorably against the FAST-DL with no significance to any measure except SNR and artifacts. And in those cases, the fast deep learning processed images were actually slightly better with significance than the standard of care exam. And I think that really is a key piece. You can see that the standard of care was much better than the accelerated exam, but when we processed it, it actually matched up very, very well. And you can also see that the fast deep learning did a nice job improving the SNR and the artifacts of the fast scan as well. So I can skip those. All right, one last piece. You can also, Subtle Medical has been used to do denoising on some of these volumetric quantitative neuroimaging protocols, which, as you know, can be very lengthy. The only question is, do they maintain their quantitative integrity? And we have an abstract coming out very soon that shows that the quantitative integrity is maintained. Now, frankly, if all deep learning did was improve signal to noise and maintain spatial resolution, it would be pretty good. But imagine if you could do something else, something called super resolution, where you can take a routine clinical target, create a low resolution, high SNR, high contrast resolution intermediary, and use deep learning to impart this spatial resolution to this image. So we get the SNR, the acceleration, and the contrast to noise of a low res image, but can train the resolution of the high res image and get this image, so that the 43-second scan is a high resolution scan which maintains the high contrast resolution as well. Here you see the routine scan, here you see the lower resolution accelerated scan, and here you see the resolution trained in from this image to this image, and creating something that looks very favorably like the original image. Now we had an abstract which demonstrated this as well. We essentially took 3D flare and ran the exams 30% faster, sacrificing signal to noise and spatial resolution, maintaining contrast resolution, and created an image with deep learning with the subtle MR, which we hoped would compare favorably against the clinical exam. Here you see the three conditions. The clinical exam, a little noisy because we're going for semi-isotropic data. You can see the faster, low resolution exam, lesions pop a little bit more, but the resolution is certainly lacking. And then here you see the resolution of this exam trained into this exam, giving us this exam, which, as you can see, is high SNR, and could probably appreciate that we haven't lost any detail and any of our contrast resolution. We call that DL fast. So we only looked at 11 patients at the time over a range of ages. I've explained that. Again, clinical exam, a little noisy, fast exam, a little low resolution. Notice the higher spatial resolution, very low, very high perceived SNR, and excellent conspicuity of lesions. These two are different acquisitions. These are the same. So there's always going to be a slight difference in positioning. So if you want to evaluate any impact of the software, compare these two. These are, could always be slightly different positions. Here again, the clinical exam doesn't look bad. The fast exam clearly looks low res. But when you actually do the deep learning processing, you can see that the resolution goes up, the SNR stays really high. And perhaps more importantly, if you look in this circle, there are two lesions here. This is really well positioned. I think the noise is hiding these lesions, but notice how we borrow the contrast resolution of the FAST exam into the high resolution of the clinical exam, and perhaps even improve quality. So in this particular trial, the deep learning was felt to be superior for all the things you'd expect it to be: SNR, image sharpness, and lesion conspicuity over the routine exam, which is a cool thing. One last thing I'd like to point out, and that is that the folks at Subtle Medical have actually got several publications where they've actually looked at synthesizing the appearance of a full dose contrast exam, but only using 10% of the contrast dose. Here you see the full contrast exam. Here you see what the image looked like at 10% of the contrast dose. And when they use their deep learning algorithm, they're able to emulate this appearance with only 10% of the dose. Here you see a little extraaxial enhancing mass, almost certainly a meningioma. At 10% dose, even though these lesions enhance floridly, you don't see it. With the deep learning algorithm, you can see the lesion pops. So again, we've talked about a lot of things today, and there are a lot of opportunities where deep learning can make a difference, AI can make a difference. It can affect the way the technologist images the patient. It can actually triage the images the way they get to the radiologist. It can actually be a right-hand man to the radiologist. It can actually be, oh, by the way, did you want to mention that something that my residents and fellows used to tell me regularly when I was in an academic center, and even after the report is submitted, it can actually vet that report and tell me whether or not the report actually has what's in the body or even on the images. So again, I think we've shown that you can enhance productivity, perhaps make better accuracy, and lower rates of misdiagnosis and affect patient outcome. We talked about a lot of things in this rather frenetic lecture, but I hope you got a sense for these tools can fit in and are fitting in day-to-day practice in neuroimaging. Thank you for your attention. There's certainly a lot of areas to be still accomplished in this space. It isn't happening as quickly as we'd hope, but probably before we turn around, it'll be everywhere. And again, we all know that Yogi always had the appropriate wisdom, but the best way to predict the future is to get involved and create it yourself. Thank you for your attention.